Welcome to Virtue Podcast, powered by Azkka Pharmaceuticals, India's first company to bring evidence-based flat pricing in medicine. Virtue Podcast brings in renowned healthcare experts as we explore the path to healthier living, where science meets virtuosity. Tune in to YouTube, Instagram, Facebook, and Spotify as we welcome our virtuous guest. Don't forget to subscribe, hit the bell icon for the latest updates, and leave your comments.
Welcome to Azkka Virtue Podcast, where we bring together clinical minds shaping tomorrow's healthcare today. Joining us is Dr. Swarup Kumar Khan, a diabetologist with a strong foundation in internal medicine and a commitment to evidence-based practice. Today's episode focuses on why tight glycemic control isn't just a guideline, it's a life-saving strategy to prevent end organ damage. From kidney failure to retinal damage and cardiovascular risk, the episode dives deep into diabetes management. Dr. Khan, welcome to the show. We are so glad to have you, sir.
Thank you, Bhavin. I'm also glad that you have come a long way to catch all these things, and we will share our day-to-day practices and prep for the patient's benefit.
Thank you so much, sir. It's a pleasure to have you. So, sir, I'll move right into the first question, that what motivated you to become a diabetologist? And since this is a very challenging profession, as we were discussing, so how do you balance your professional and personal life?
इसका आंसर बहुत ही सीधा है। जैसे कि हमारे देश जो इंडिया है, इसमें सब कोई बेटा बेटी मम्मा का लाडला होता है। सो बेटा और थोड़ा सा खा लो, अरे तुम तो कुछ खा ही नहीं रहे हो। ये करते करते हम लोग ज़्यादा खाते खाते आज के दिन में डायबिटीज़ कैपिटल बन गए हैं। अब देखो, एक चीज़ और भी है कि हम लोग को क्या कहा जाता है, इतना प्रोग्रेशन के बाद भी इंडिया इज स्टिल अ थर्ड वर्ल्ड कंट्री। तो इंडिया को थर्ड वर्ल्ड कंट्री से फर्स्ट वर्ल्ड कंट्री में कौन लेके जाएगा? आगे जाके ये जो जनरेशन है, न्यू जनरेशन विल लीडर्स टू दैट। तो इसका पॉइंट यही होता है कि ऐसे एक महामारी जैसा कि बीमारी ये डायबिटीज़ है, और इसके साथ और बहुत सारे बीमारी भी साथ में लेके आता है, ये हाइपरटेंशन, कार्डियोवास्कुलर डिजीज़, और इसके चलते इतने की मौत होते हैं, स्ट्रोक होते हैं, और रिहेबिलिटेशन प्रोसेस चलता है कि ये दिस इज़ समथिंग विच विल पुल यू डाउन। तो इसीलिए अगर आगे बढ़ना है तो डायबिटीज़ को केयर देना है। और मैंने उसी टाइम पे ठान लिया था कि अगर इफ़ यू ट्रीट डायबिटीज़ वेल, तभी जाके देश आगे जाएगा। तो इस सोच को ही आगे रखते हुए मैंने डायबिटीज़ को बहुत ज़्यादा प्राधान्य दिया, और डायबिटीज़ के ऊपर इतने सालों से काम कर रहा हूँ। एकदम सही बात है कि एक प्रोफेशनल आदमी के लिए संभव नहीं है दोनों को बैलेंसिंग करना। If you are really a professional guy, then you have to do for the betterment of for the patient as well as of your own, क्योंकि लर्निंग एक कॉन्टिन्यूस प्रोसेस है। जो डायबिटीज़ के चलते इतने सारे रिसर्चेस हो रहा है कि उसके साथ आपको जाना है। हर कोई इंटरनेशनल और नेशनल सिम्पोजियम जहाँ पे डायबिटीज़ रिलेटेड ट्रीटमेंट डिस्कशन होता है, वो उसको आपको अटेंड करना है, आपको घर में आके पढ़ना है, आपको एडवांस कोर्सेज करना है। तो इसके चलते हुए आप उसके बाद पेशेंट भी देखना है। सो मैनेजिंग योर पेरेंट्स, मैनेजिंग योर वाइफ एंड किड्स एट होम इज़ रियली नॉट हैपेंड। कोई भी एक प्रोफेशनल हो जिसके उसूल्स अलग होते हैं, लाइक आपको पेशेंट केयर और पेशेंट के ऊपर आपको आगे प्रायोरिटी देना है, तब जाके कहीं ना कहीं तो आपको ये कम हो ही जाते हैं। तो इसीलिए आई थिंक कि दिस इज अ सैड पार्ट ऑफ आवर लाइफ।
एंड सर, आपने जो कहा कि आई एब्सोल्युटली अग्री कि जब एक डॉक्टर होते हैं, एक लीडिंग डॉक्टर जैसे आप है, तो इट इज़ नॉट ओनली यू, इट इज़ द फोर्सेस फ्रॉम द फैमिली, फ्रेंड्स, योर टीचर्स, देयर आर लॉट ऑफ सपोर्ट विच गोज इन and ultimately makes a doctor and where you stand today. So these are the people, I absolutely agree that it is a thankless job that they are doing. So this takes me to the next question, that we hear about the word tight glycemic control. So can you sir explain us that what exactly is tight glycemic control, and how tight is tight enough that really clarifies this question?
देखिए, बाय लिटरेचर अगर हम लोग जाते हैं, अभी एकदम क्लियरली बोला गया है कि HbA1c अगर आपका 6.5 के आसपास में रख सकते हैं, दैट इज द टाइट ग्लाइसेमिक कंट्रोल. Keeping tighter more than that, like if it comes down to 4.5 to 5, then it has been seen in some researches that, and those research works prematurely stopped because so many patients died due to the severe and tight control of the sugar. So this keeps you going in that sense that you keep average of 6.5 HbA1c, and at the same time you see the fasting and pp sugar for your patient, and keep it in that way. This does not mean that you will see HbA1c only and you will treat your patients. You need to see the fasting and pp as well. But yes, tight, how much tight it might be. For the younger people, even you can keep HbA1c from 6 to 6.5, where patient is not feeling well, patient is not facing hypoglycemia like uh, side effects, then you can go for it. But definitely the same thing is does not stay for the older patients, where you need to keep it around 7. If you make a tighter control, then the patient might silently goes into the neuro hypoglycemia. और मैंने बोलने से है कि आपको इसमें हार्ट और ब्रेन्स दोनों में इफेक्ट करते हैं. एंड while स्लीपिंग, while walking outside, silently patient may pass into a sudden cardiac death like situation. So elder patients के लिए टाइट आप 7 के अराउंड रखोगे. For senior citizens more than 65, it is always better.
So, sir, this also makes me curious to ask that is there any specific critical window, like the legacy effect, where early glycemic control has long term benefits, even if control worsens later?
Yeah, definitely yes. The legacy actually it says that if you keep tight control of the sugar right from the beginning, then those side effects or ill effects does not happen, or the good effects being carried forward. So what does that mean? That diabetes is a disease which ultimately affects the cardiovascular system. So it causes the heart attack, brain stroke, kidney failure, or the diabetic retinopathy to happen. So why it happens? Because of your glycemic control is not tight. So the thing is, at the end of the day, it has been seen that if you keep the sugar in a good level you want for the individualized patient, then the legacy effect, that means the good effect carried forward long enough, that so that at the later part of your life, say after 10 years, if the even if the sugar is not controlled, but the side effects are not seen. But right away from the beginning, if your sugar is not controlled and if you're not taking care of the comorbidities, then what happens, within 5 years of time the patient gets all those comorbidities as well as death or death like experiences that are not to happen. So it is very much important that this legacy effect, which are, this is very much genetical phenomena. So when you give a medication, when your body is acclimatized in that sugar or lipid or whatever parameters are within the body, that memories are kept into the genetics. So it follows that genetics, it turns out the hormones in that way so that the effects are long lasting. And so that's why, as you rightly asked, that even if the sugar control is not that much good in the later part of life, still the patient is saved, guarded.
So that is very nicely articulated. You actually clarified a lot of things. This that analogy, really brings it home that early control isn't just a phase; it is a foundation,
Definitely.
as we understand. And knowing it has a lasting impact can really change how clinicians and patients think about, those first few years of diabetes. So, sir, this also brings me to the next question that some clinicians worry that tight control increases the risk of hypoglycemia. Partly you mentioned that part as well. So how do we strike the right balance between safety and efficacy?
See, hypoglycemia is a phenomena in which should not happen to our patients. A physician who is treating his patients must be clever enough to choose the patient. Like whenever he is choosing a patient of younger age, the treatment part must be different from the patient he is getting of older age. What does that mean? It means that few medications are there which are to be offered in the younger and which are not to be offered in the elder one. Like one is sulfonylurea, like medication. It can cause weight gain, it can cause hypoglycemia, and obviously the insulin, which can cause hypoglycemia if it is not added properly. So the idea is that whenever you're choosing your patient, say for an example, that elder patient, if you have to write sulfonylurea like medications, you write down lower dose initially, tell the patients for follow up after 4 weeks and see the glycemic control, and after that you can add on top of that if it is needed, but it must not be given at night. If you give, then there is a chances of hypoglycemia in those patients in the elderly. And number two, if you are giving insulin for any patient, be it elder one, be it a younger one, the dose must be escalated gradually. You have to start the lowest dose of the insulin. You have to make it a calculation of 2/3 in the morning, 1/3 at night, and after say around 10 days or 7 days, you ask the patient for follow up at your chamber for after repeating the sugars, so that you what amount of insulin is to be escalated you must calculate, and obviously that those should not be hell and heaven difference. It must be very gradual. So these are the things where you strike while choosing your patient, and definitely you should choose insulin and sulfonylureas before a major meal. If there is a chance of hypoglycemia when patient is not taking food for a longer period of time due to the lifestyle, or maybe as you can say people who are worshipping or offering pujas and keep fasting like Ramadan, or maybe for the other deities, they may have got this hypoglycemia. If they are going for a fasting long enough, you have to modify your thoughts, you have to modify your treatment by that time. So this is it. Hypoglycemia will not happen if you are choosing your medications properly and individualize the treatment according to the patient's profession.
Very true. So it requires a customized approach, as you say. So that's such a thoughtful distinction, that precision and not aggression.
Yeah.
So it shows how tight control doesn't have to mean risky control if done with the right tools and the mindset. So sir, this also brings me to my next question, that are there differences in approach when dealing with type 1 versus type 2 diabetes, and especially when targeting end organ protection?
Yeah, definitely. I think whatever literature says, ultimately see the thing is, if diabetes is there, definitely type 1 diabetes deals with from very early age, from the
Right.
childhood. And type 2, it used to occur at or more than 40 years of age, though it is not true for nowadays.
Right.
It can have so many names,
Hmm.
whatever are names there, means you
Hmm.
can have it by the age of even 20.
True.
So that is also counted as type 2 diabetes. Whatever may be the cause, if the diabetes is not controlled, then you can imagine that the journey of your life, you have caught up at 10 years of age, you have to live 70. You have caught up at 40 years of age, you are living 70. So type 1 definitely, if it is not controlled, then it tend to cause more damage to your organs. But yes, what happens, like since it is I mean to say diagnosed very early, it has to be, I mean, so and if you keep the tight control of the sugar, as like I can give you an example, that Wasim Akram, acclaimed first
Right.
bowler,
Right.
and he's still living. He was type 1 diabetic. He used to take
Right.
insulin before he
True.
comes to the ground.
I remember, so he was one of the first few who came out very openly.
Yes.
Absolutely.
So that was the time we hardly had the name of diabetes, and this has come up. And so the thing is, if there is type 1 diabetes, you need to be more cautious,
Right.
because patients are mostly dwelled on insulin. So that pricking pain is there. What happens is, on the side of the patient's inertia due to the pain, or due to repeated testing every week or every day, so what happens, like, if even after that also, if you can have a good control, then it is better, or it offers protection to your organs.
Right.
But yes, for type 2 diabetes, whenever this comes to in your life, it comes with other comorbidities as well.
True.
Like the hypertension, like the atherosclerosis. So and and people probably accepting the disease has happened takes another few months or years to get good control of that.
So true.
So in both of the cases, I think that we need good control, because see, all those, say, CABG, or the bypass operation, or the stenting of the heart, or maybe the kidney damage, or whatever is happening, mostly we see that these patients get all these things after 40 years of age.
True.
And by the time one I mean to say, gets this diabetes type 2, before that his liver is damaged or deranged liver function, and that has led to some the changes within the body, which ultimately leads to the diabetes. That is a new concept that has come up. So it's very recent concept. Worldwide research was going on. So in both the cases, you need definitely good control. But yes, for, as I told, that the life of the type 1 diabetes that starts early in the life, you need to be more cautious.
So sir, it's pretty fascinating, how the strategies differ, but the underlying principle remains that early proactive care is something which is required. So it highlights the complexity of diabetes, but also the possibilities we have, if we act in time. So that will play a major role, I feel.
Definitely.
Right. So, sir, how do you individualize glycemic targets, say for an elderly patient versus a younger person with early stage diabetes?
Yes. See, one thing is there. I think this is a very good question, and that will carry very good message to the patients.
Right.
Because, see, a young diabetic who is coming, definitely nowadays people are more phytogenic of outside food.
True.
We hardly take cooked by our mothers, but we are more inclined to the pizza
Junk.
and etc. junk and fast foods.
Right.
Okay, for part that is good, but new generations are really addicted to it.
True.
So if you want to be a good physician at your chamber, you cannot stop all these things.
So true.
This is practically true. So the patient will not visit for the second time, where I can offer him a better treatment.
True.
So let it be. I cannot make one understand, or maybe I just want to understand the extra effect or extra calories from the foods. But yes, managing on a young diabetics side, I will pursue more of physical activity,
Right.
which I cannot offer it to the elder one.
Right.
So
Lifestyle modification.
Lifestyle modification. So have food, but at the same time you work out, and definitely giving medications which will cut off his sugars from the diet. There is a medication, we call it voglibos or acarbose sort of medicines, which if you offer, then they do not allow the sugars to be absorbed from the gut. So patient will take the food as because of his feeding center, or of his mental status, whatever. But what will happen, like extra sugar will go through that thing. Again, if the comorbidities are there along with it, there are other medications like nowadays it must be offered that the SGLT2 inhibitors.
Right.
So that is a discovery which has really changed the total scenario
Very
of the
true.
patient treatment. So we can offer this thing to the younger generations right from the beginning. So that will automatically put
Right.
his weight in a control state. So it will differ from elder one, where elder patient, he will be sedentary. I cannot make him move around.
Right.
It will hurt his knee
True.
and other joints. So let cut short lifestyle part. We will go for only medication and approaching towards this kind of patients. You have to be like patient enough not to be aggressive for these patients directly from the day
Right.
one. So we can give medications to these patients. Let's have a repeated blood sugar checked up, and after that we can offer those medications which will not harm to this age. As I told you, that sulfonylureas may not be or must not be given a patient of 90 years old patient. If you have to offer, give a smaller dose of it at maybe 70 to 80 years of age, it must not be given at night. So these are, if you have to give it in the morning. So like SGLT2 inhibitor, you should not be giving it at night. You should be giving it in the morning hours or maybe the before lunch hours.
Right.
So for these patients, because these patients can turn into UTI or urinary tract infection very likely. So you have to offer such kind of medications which will not introduce other hazard as well in his body due to you. So that is the thing. I become very much cautious regarding treatment in the elderly, and which is I can say my hands and mind is open towards the younger generations. That I think differentiate my treatment for this.
So that's what, sir, we really appreciate, how a doctor has to wear patient-centered lens, as we call, to ensure that there is a tailored approach for different kinds of patients that come into you. So, sir, it shows respect for both the science and the person behind the numbers, and that flexibility, can make, the care more sustainable, I would say. Having said that, sir, what's your message to physicians who hesitate to intensify, therapy early, perhaps due to therapeutic inertia or patients pushback? Because patients also have a lot of resistance when there is a intensification of the therapy which happens. So how do you deal with that?
Yeah, definitely. It's really a very much problematic part on the treatment from both sides.
True.
But first of all, I will take first of all on our side, the physicians, that there are inertia in few physicians to give treatment, to offer in an aggressive way, because whenever a patient comes on your first visit, okay, fine, you may not be aggressive until and unless complications like infection is attached with it. You have to be aggressive, even if it must be brought down with insulin if it is needed by that time temporarily. So patient has to be called upon your chamber in a regular interval for few months. Maybe for coming 3 months, you can ask them to come for every month to check whatever you have given, not to be aggressive. And because patient maybe is taking medicine from previous prescription of other doctor, so be generous enough. Patient must be treated. Even if you have lesser income, or if you do not get money for in every visit for few patients, even if you call them upon to see what is going on after your medication has been given, because of the cost attached to it, so many patients do not turn up in 1 or 2 months when we say. So if they are if the confidence of the patient is taken into your side, and obviously talk with them, make them understand that this will be so, this will be like so be patient.
Hmm.
And after that, you go on escalating up or escalating down your
Right.
treatment. So being aggressive in the sense always not being up, yeah, it sometimes be going down
Yeah.
also.
True.
So definitely this inertia is should not be there. Like as I
Hmm.
told you, like giving insulin at night and causing hypoglycemia in very early hours in the
Morning.
like 3 o'clock in the morning.
Wow.
That again in a rebound phenomena causes sugar to be getting high in the morning.
Hmm.
So whenever that is coming to you, instead of checking the sugar once at 3 o'clock in the morning, you are intensifying the night dose. That will cause, again, that is a vicious cycle, that will cause more
Right.
hypoglycemia and more sugar increase on the morning. So
Okay.
these are to be taken into considerations. Be less aggressive.
Hmm.
So sneak into that thing, why it is happening. So
Right.
this is the inertia of our physician side.
Okay.
And definitely for the on the patient side, it is definitely there. See, being a normal person till 40 years of age, now I am getting illness which will not be going away for the whole life. I have to
Right.
take medication.
True.
So that is what I tell every patient who is coming for the first time or diagnosed for the first time in the chamber, that see, you just erase from your mind that you do have diabetes.
Right.
I will take care on your part. You just take the medicine. You just do the test and come to me in a regular interval.
Right.
But putting that extra emotional part on their brain, I'm having diabetes. What will happen to me?
That
Oh,
lack of
I am
acceptance.
sick. That acceptance, that is it truly said. I tell them that accept the disease, that
Right.
you do have it.
So true.
So that is the first thing I counsel
Absolutely.
with the patients. So let them understand, then they come down, then only you can go for the treatment. So that is, I think, to the physicians, I want to straightway give this message that yes, for the inertia of the patients, you just talk to them, and after that, whatever needed, you should go for your treatment. Then everyone has their own strategy of treatment that should be. And obviously, when a patient needs insulin, most of the times we come across this problem. I will not take insulin. I'll take rather 4 more oral medication, but not.
Right.
So in few cases help for few months, but not every time. So whenever it is needed, it should be offered. It must be offered, and you have to again take the confidence of the patient to let them understand in their language they should do, and continue treatment.
Absolutely. So, sir, very rightly clarified, and that's a bold but very necessary message that you gave. Therapeutic inertia is real, but so is the cost of hesitation, I would say. Your approach, reminds us that timely care is not aggressive; it's protective. So this leads up to the next question, which a word which we hear a lot these days, which is technology. So technology is taking over, changing truly in all the fields, not only in the field of healthcare. So, sir, what do you feel that has technology changed in the field of diabetes for doctors as well as patients? And do you really feel that with technology coming in, patients have got in better control of the disease?
Truly said. Absolutely true. And hats off to the researchers. And from the researchers' hand to the hands of I think the pharmaceutical companies and the hospitals or the clinics, whoever are using this technology for the benefit of the patient. Because of why, first of all, there are much changes in the diagnostic part of the patients, because initially what happened, you used to take this from the syringes and from the investigations lab only. Followed by that, the glucometer came up, and following that, now it is that continuous glucose monitoring machine has come up, for which you can have the real-time data.
CGM.
CGM, yes. So CGM, you can put it in the patient's body. So after that, at least you can have those data, and how fluctuations are going on according to the treatment, how much glucose is coming down or going up. That's truly makes sense. and it has come up into the market, but with a higher price, who I mean to say everyone cannot afford. But I think hopefully in the future, patients, so many patients, even if not everyone, can afford this part of treatment. Second one is like development of softwares, which has led into the analysis of a part of the patient's every details. So making patients aware of the fact that the testing part, that you have done this testing maybe 3 months ago, maybe months ago, or you have not gone to your doctor months before you have done it. So all these things through general messages, or it is now coming up through some apps whichever are offering by the, I mean to say, companies, some companies. Definitely people are using Android phones and getting those apps freely, and there will be reminder messages and calls even. So there are call centers dedicated to this, and definitely there are nowadays they have kept dietitians to tell you on the part, because I think doctors don't have that much of time every time to keep all those things detailing to the patients. But whenever they, like me, I do the detailing food also for the patients, how much exercise for the patients. But I think that everyone cannot do this, and these are taken care of from the company side or this newer app side. So these are truly wonderful. I think this will come into a better way, in a bigger way to the patients, then that will cause more sustained betterment for the patients. So until and unless you do the test, until and unless you are aware of the fact that something is slipping into your life, so people will not learn. But when there is a continuous striking in your brain through this, you are ought to move someday. You cannot be that much inertia in your within that you just stay and doing nothing. So I think this is a very good part. It has to come. So
absolutely. So the technology, I would say, I was also recently talking to someone where we also came to know that even medical insurances, so they have created an app where to their clients, if they take number of steps, X number of steps in a year, they give discount on the premiums.
my God.
So, so I
What a
absolutely
beautiful
agree,
thing.
and I so agree to what you say, that technology has its positives, and I'm sure with all these things, patient will feel in better control of the disease.
Definitely is.
Right, and so this also makes me very curious. I'm continuously curious about one thing, and while we are shooting this, my eyes are going on this. This is something interesting, which I would like to know, sir, from you. What is this blue paint or something? I don't know.
This is something. Whenever you get all these things in someone's bodies, these are tattoos,
Okay.
and you are sure of it that you do have some kiddos at your home, especially daughters.
So true.
So
true.
say they have true love for the father,
Okay.
that they are all they have all tattooed in their bodies and faces. At least your father should have one, at least not in the face but in the hand. So my daughter, 3-year-old, and one 11-year-old, they have pushed me to do this thing, and this
So
is
true.
great.
And this is your reflection of love as well, that you have still kept it.
Yeah, but what happened, like my elder daughter told, okay father, are you eager to go for it? I told yes, why not. Then she told, okay, I'll put it in your bag so that no one can see. And I told, why not? It must be shown outside that you have given me
Wow.
the gift. So I told them that no, just make it here only.
Wow, that's so sweet. So, sir, this also, brings us to a very exciting session of this podcast, which is the rapid fire round.
Okay.
So we, have in all the talk shows and everywhere.
Yeah.
So we thought, why not add it in this podcast? And doctors facing a rapid fire would be something very interesting.
Okay.
So, sir, are you ready for it?
Right. I'm really ready for it, but I just want to say, for before every rapid fire session, like I have seen it in Coffee with Currents or something, means they have kept some gifts for that. Maybe some sugars or that in a
Absolutely.
diabetic in a diabetic talk up.
Right.
Yeah.
So
Okay,
yeah,
please go
we
through
have a
it.
gift for you as well.
No, no. I was just joking. Please go for it.
Right. Are you ready, sir?
Yep.
Yeah. Your favorite sweet food, I would say, you wish was low glycemic index approved.
Oh my God. I think it must be mango for me.
Okay.
So, like, we Bengalis are very fond of mangoes out here.
Right.
So, had it been a better, lower glycemic index, I would
Mm.
have. Not only me, I
Most
know
of us.
so many patients are there who are
Mm.
very much fond of this. So, I
So true.
could have pushed the mango towards them also.
Very true. Even I love mangoes.
Okay.
One organ that silently suffers the most from poor sugar control.
I will not go as per literature, but in my experience, if you say that should be in between the heart and the kidney.
Right.
Though eyes is also there, but I will go for heart because that is a thing, a pump which cannot be revert back once it is gone.
So
For
true.
kidney, you can make a dialysis, but for the whole, for even the
Yeah.
heart musculature, means the blood vessels, you can go for the CABG, PTCA, etc.
Hmm.
But for the musculature, we do not have the answer. So if it is gone, it is gone. So I think heart is the most important, which passes off silently through the diabetes.
So true. A one-word warning you would give to someone ignoring pre-diabetes.
It must not be ignoring, because pre-diabetes is the window which through the whole, I can say, on the other side, the whole ocean is waiting to be flooded with.
Wow.
So this is it. I think there are so many stories people have heard. This is just striking the right chord when you are pre-diabetes, that some bigger is coming on to your way. So be very much cautious to hold from that time onwards to meet doctor, to change your lifestyle, and to go for the treatment if it is needed.
So don't be ignorant about it.
Yeah.
So what's one food that patients refuse to give up, no matter what you say?
Oh, I think for a country like India, it is rice. Most love for rice, right from the beginning, at breakfast, at lunch, at dinner, and even maybe they're in their dreams also. So, in the most part of the thing of our country, this is rice. Maybe the chapatis as well in the western part of our country or northern part. That is
true. So, which is harder, lifestyle modification or adherence to medication?
No, it is always about lifestyle modification.
Okay.
Because remembrance, you can have the medicine on time. That is, maybe you just take it, you just don't test it, right? But for food, even to lifestyle modification, that definitely the bigger part is the food. So for food, you pay, you earn for having food. That is the main part of our life. So the thing is that if you cannot taste your good foods in your life, there is no use of it. Being a diabetic at a younger age also, I just don't find anything, because that is exotic or exciting thing. Food, loving food or having food in your mind, that gives you a dopamine surge, that keeps you well. So that must go on. And for people really, it's entertainment, even for me too. So I just don't want to burden my patients by stopping the food. So I think that is the more harder part than
lifestyle
pills.
modification.
Yeah.
Right. Wow. So, sir, this also brings us to an end of a wonderful conversation that we had. And I would really like to thank you, sir, for highlighting that, why tight glycemic control isn't optional. It's essential. To young doctors, if you manage diabetic patients, this conversation may reshape how you approach the very first prescription. Your insights, sir, remind us that preventing end organ damage starts with precision at the very first step. And to all our listeners, Keep learning, keep leading. Thank you so much, sir.
Thank you so much. And I would like to thank you, especially Bhavin, because you were so nice right from the beginning, so cozy. I didn't have any problem to share my datas or my experiences along with you. And this is really truly good on your part that you have asked doctors to go for these things, and because it will help the community. That is the only thing.
Absolutely,
Messages
sir.
must go to the community
Absolutely.
like in this way, and every expert should share their opinion in such a way to for the betterment of the patients.
Thank you, sir. Thank you so much. It was such a pleasure to have you. Thank you.
Thank you. Thank you.